Hello, and welcome to the July edition of Sepsis Chatter. My name is Susan Von Bossi, and I am a quality consultant for Registry Partners Incorporated. Today's presentation is titled Severe Sepsis and Septic Shock Exclusions, COVID-19, Administrative Contraindication to Care, Directive for Comfort Care, and Palliative Care. We will discuss how to determine if the documentation is sufficient to exclude an encounter from the SEP1 measure. The information provided in this presentation is based on the CMS Specifications Manual for National Hospital Inpatient Quality Measures, version 5.12, discharges July 1st through December 31st. We are all familiar with certain documentation and conditions that will exclude a patient from the SEP1 measure. Some of the more straightforward examples include antibiotics administered greater than 24 hours prior to the onset of severe sepsis, the patient who expired within 6 hours of the onset of severe sepsis or septic shock, or the patient who is discharged or transferred out of the facility within 6 hours of onset of severe sepsis or septic shock. Some conditions that would exclude an encounter from the SEP1 measure are not as easily defined, and even the most experienced sepsis abstractor sometimes agonizes over how to abstract these cases. The most common scenarios seem to generate the most questions about excluding cases are the COVID-19 documentation that would qualify as administrative contraindication to care, and also documented directive for comfort care or palliative care. This discussion will focus on the guidelines and the examples from the most current data dictionary, as well as QualityNet question and answer tool responses related to the related queries. COVID-19 is not resolved, and we will continue to see it suspected and diagnosed in the course of our reviews. So I wanted to go over some clarifications and updates provided by the QualityNet question and answer tool related to a few different COVID-19 scenarios. First, let's start with the basics. The guidance. A patient will be excluded from the sepsis measure if COVID-19, COVID, or coronavirus is documented as diagnosed or suspected. The Specifications Manual includes abstraction guidance to select Value 2, no severe sepsis, if there is provider documentation that COVID-19 is suspected or present. Diagnosed or suspected COVID must be documented by one of the following providers: a physician, advanced practice nurse, or a physician's assistant. An RN, pharmacist, or case manager documentation is not acceptable. An EMS run sheet may include suspected COVID, but again, the EMS staff are usually EMTs, paramedics, somebody like that, so they are not acceptable licensed providers for the purpose of this data element. In response to a recent query, the QualityNet question and answer tool provided the following guidance. For documented and suspected COVID-19 followed by negative COVID test results, if there is provider documentation that COVID-19 is suspected or present, select Value 2, No, for severe sepsis present, even if the COVID-19 test comes back negative. Let's take a look at this example. The MD documented bilateral pneumonia, suspected COVID-19. A COVID test was ordered and collected while in the emergency room. The result came back negative. In this example, select No, Value 2 to severe sepsis present. For abstraction purposes, the documentation does not need to be supported by a positive test, and it is not negated with a negative test. In other words, suspected COVID-19 does not need to be followed by a positive result or an official quote-unquote diagnosis. Contradictory documentation of a COVID-19 infection within 6 hours of documented suspected COVID infection would not negate the original documentation of COVID-19 when determining if severe sepsis is present. Let's take a look at an example. This scenario was submitted to the QualityNet question and answer tool to obtain clarification related to conflicting provider documentation. The ED-MD documented the following. This patient presents with cough, aches, fever of 103.2, and severe headache. She has not been vaccinated for COVID-19 based on presentation and vaccination status, suspicious for COVID-19. A COVID test was ordered and collected while in the emergency room. Within 6 hours of the emergency room doctor's documentation of suspected COVID, the attending's H&P includes the following. Patient with bilateral pneumonia, COVID test negative, patient does not have COVID. In this scenario, we would still select value 2, no, to severe sepsis present. This guidance applies to the patient who presents with severe sepsis and days later, another physician documents that COVID is suspected. Select no, value 2 for severe sepsis present. This guidance does not provide a specified time frame for the physician documentation that COVID-19 is present or suspected. So, documentation at any point in the medical record would suffice in order to select value 2, no, and exclude the case. COVID-19 is also considered present or suspected when it is accompanied by one of the following qualifiers: possible, probable, likely, or suspected. I recently received guidance that states to not use a differential diagnosis of COVID-19 for suspected COVID. This is actually in line with the new guidance starting with the July through December discharges and is included on page 1-133 of the data dictionary. It states do not use the positive and negative qualifier table for COVID-19 documentation. And they specifically stated that differential diagnosis is one of the positive qualifiers that we would not be using to determine if COVID is present or not. The guidance clearly states that we are to use this table for an infection, severe sepsis, or septic shock. And now the new guidance clarifies that this does not apply to situations including COVID. Let's move on to administrative contraindication to care, refusal of a blood draw, IV fluid administration, or IV antibiotic administration. Acceptable documentation can be by a physician, advanced practice nurse, physician's assistant, or a nurse, that the patient or authorized patient advocate has refused either a blood draw, IV fluid administration, or IV antibiotic administration within the specified time frame. In order to exclude a case due to the refusal of care, the refusal must be documented prior to through 6 hours following the onset of severe sepsis or septic shock. The guideline does not define a time frame prior to the onset of severe sepsis. We would select value 1 if there was more general documentation of refusal of care or documentation of patient noncompliance with care that could result in IV-IO fluid or IV-IO antibiotic either not being administered or being administered late due to the noncompliance. This applies to severe sepsis and septic shock, and some of the reasons could be the patient's extremely combative and the staff can't render treatment, pulling out IVs, refusal of IVs, refusal of a central line, refusal of pressors. Any of those would qualify as refusal of care, and you could select value 1 and exclude the case from the measure. In addition, if a blood draw is refused, you may select value 1, yes, for administrative contraindication to care. However, the test must meet the requirements of the Step 1 measure. So if they're refusing a point of care blood glucose, that is not going to qualify as administrative contraindication to care, and you would not be able to use that as a qualified refusal. Just keep that in mind, please. Let's take a look at the following example. This patient was a direct admit from the oncology clinic with signs and symptoms of severe sepsis. The official onset time of severe sepsis was 10 o'clock. Labs, blood cultures, and antibiotics were immediately ordered, but the patient did not want to have an IV started or blood drawn until she talked with the attending, since she has a port and would rather use that if she can. At 13:30, the attending okayed using the existing port, and the labs and blood cultures were collected at 13:45. The patient's refusal delayed treatment, so we would answer yes, number 1, to administrative contraindication to care, and this case would be excluded from the measure. Let's take a look at another example. This patient was admitted to a med-surg floor from the ED at 12 o'clock. Soon after arrival to the floor, the patient's IV infiltrated. The RN notified the patient that the IV needed to be removed and replaced, and the patient stated that he was not getting stuck one more time and forget the new IV. After unsuccessful coaxing, the RN contacted the attending to speak with the patient about the importance of the IV and the need for reinsertion. At 1300, the patient met clinical criteria for severe sepsis, but still refused the IV. The attending met with the patient at 1600. The IV was started, and Rosefin 2 grams IV was administered at 1630. In this example, the patient received his IV antibiotics, only they were 30 minutes late. The case would have failed for the antibiotic data element, greater than 3 hours following the onset of severe sepsis. But because the patient refused a new IV, this could have delayed the administration. By selecting number 1, yes, to the administrative contraindication to care, this case is excluded rather than failed. Let's talk about the guidance related to the patient leaving against medical advice. This is considered refusal of care. Explicit left against medical advice documentation is not required. An example would be that the patient is refusing to stay for continued care. You would select value 1 in that scenario. You would also select value 1 yes for administrative contraindication to care if any source states the patient left against medical advice, regardless of whether the AMA documentation was written last. Comfort care and palliative care as an exclusion. Comfort care refers to the medical treatment of a dying person where the natural dying process is permitted to occur, while assuring maximum comfort. Palliative care, on the other hand, is the identification, prevention, and treatment of suffering by means of assessment of the physical, psychosocial, intellectual, and spiritual needs of the patient with a goal of supporting and optimizing the patient's quality of life. The only acceptable providers who may document comfort measures only, or palliative care, or any other acceptable inclusion term is a physician, advanced practice nurse, or physician's assistant. The specified time frame for documentation is before or within 6 hours after the presentation of severe sepsis or septic shock. This is not to be confused with the conditional orders such as DNR, DNR-I, DNR no chest compressions or intubation. Physician, APN, and PA documentation of an inclusion term documented in the following context is acceptable. Comfort measures only recommendation. Order for consultation or evaluation by a hospice care service. Patient or patient representative requests for comfort measures only. Plan for comfort measures only. Referral to hospice care service. Please refer to this list in the data dictionary on page 1-53 in order to determine if the documentation qualifies as comfort measures or palliative care, and the case would be excluded. State-authorized portable orders, or SAPOs, are the only pre-arrival documentation that can be used as CMO. Some examples that you may see in a medical record are a DNR comfort care form, a medical orders for life-sustaining treatment form, which is a MOLST, or physician orders for life-sustaining treatment, a POLST, or an out-of-hospital DNR, an OOH DNR. A patient on hospice at home or palliative care in a nursing home is not considered CMO unless it is mentioned or ordered during the current encounter. You would select value 1 if a SAPO lists different options for CMO and any CMO option is checked. For cases where there's a SAPO in the record with a CMO option selected, you would not use the SAPO if there's documentation on the day of arrival up to severe sepsis presentation indicating the patient or the patient's representative does not want CMO, and there is no other documentation regarding CMO found in the record. This is an example of a national POLST form, a portable medical order. In section B, you will see that there is a selection, comfort-focused treatments. The goal is maximizing the comfort through symptom management, allowing a natural death. This form needs to be filled out by the patient advocate, and also the physician. It also needs to be dated. We would not accept an undated form as CMO, as evidence of CMO, and we could not exclude a case based on that if it was incomplete. So that's just something to keep in mind as well. Remember that the specified time frame in order to see one of these is before or within 6 hours after the presentation of severe sepsis or septic shock. This is just the second page of the medical orders that we were just looking at. And a couple things to keep in mind. An authorized patient advocate is someone who is authorized to make decisions on behalf of the patient when the patient is not able to. Family members, medical power of attorney, healthcare power of attorney, durable power of attorney for healthcare, someone documented as an agent for the patient, an attorney in fact. Those are all considered authorized patient advocates that can speak for this patient when they can't speak for themselves. Let's take a look at a scenario. This patient met criteria for septic shock on 1/2 at 12 o'clock. The patient has been diagnosed with stage 4 liver cancer. He is currently ventilated and unresponsive, but is still receiving aggressive treatment. The patient's advance directive indicates his desire for full treatment, and the patient is ordered full code. The patient's wife is his medical power of attorney, and she's honoring his wish. At 1600 on the same date, the patient's daughter states that he has no chance for recovery. He would not want to remain intubated in this condition. She has requested that the patient be moved to comfort measures only. At 1630 on the same date, the attending documented that he will discuss the patient's prognosis and CMO with the patient's wife, who has the current medical POA. So the question is, would we accept this documentation as CMO and answer number 1, yes, to Directive for Comfort Care? And the answer is no. This would not qualify as comfort measures only and exclude the case. Even though the documentation is within 6 hours of onset of septic shock, the patient's wife meets the definition of authorized patient advocate and not the daughter. Therefore, she would be the representative to formally request and approve comfort measures or palliative care. Also, the attending documented a plan to speak with the patient's wife, the patient's advocate, but he has not documented the discussion or the final decision regarding moving the patient to comfort measures only. You would answer, no, this is not a patient who qualifies for comfort measures only, and this case would not be excluded, at least for this reason, at this time. Before we wrap things up today, I'd like to take a look at one last scenario. The MD noted on Monday at 15:20 discussed hospice services with family earlier this morning, and they have requested palliative care at this time. On the following day, Tuesday at 1700, the MD documented patient has severe sepsis with septic shock. The question is, does this documentation qualify as a directive for comfort care, palliative care? The answer is yes. Select value 1 for the directive for comfort care and palliative care. The documentation is on the day before severe sepsis presentation time, and that indicates the family requested palliative care. Now that we are at the conclusion of today's presentation, I'd like to leave you with a few takeaways. While some documentation that would exclude the encounter from the SEP1 measure can be easily interpreted, this discussion was purposely focused on the not so easily interpreted documentation that you will most likely encounter during your abstraction career. So a couple of tips to go over. If time-sensitive labs or interventions have been missed or are performed late, remember to look for clues that the patient refused care. Scanned SEPOs are the only outside CMO orders that will exclude an encounter. Keep the acceptable time frames prior to and following the onset of severe sepsis, septic shock in mind when abstracting. Always have your data dictionary handy whenever you abstract. And please don't be afraid to contact QualityNet question and answer portal with questions. I put a link on the reference page. They have been amazing. Thank you for watching today. Please join me next month when the sepsis chatter topic will be severe sepsis, abstracting the correct initial IV antibiotic, date and time. Also, please refer to the resources listed for further information related to the SEP1 measure abstraction. And happy abstracting. Thank you.